Collaborative. I'm Melissa Parkerton. I'm the director for the PACT Collaborative, and it's my pleasure to facilitate today's roundtable. Just to explain the structure a little bit, we're going to begin with introductions of our convening partners, Dr. Evan Benjamin from Ariadne Labs, Dr. Tom Gallagher from the Collaborative for Accountability and Improvement, and Allison Perry from the Institute for Healthcare Improvement. Tom and Evan will then offer a high-level overview of communication and resolution programs and how PACT will promote their cultivation. And then we'll open up for your questions. If you have arrived today with questions ready to go, please feel free to drop those into the chat anytime, or you can just hang on to them and ask them aloud yourself when we get to the discussion portion of our time together. With that, I would like to invite you to introduce yourself, Evan.
Well, hello, everyone. Nice to see everyone. I'm Evan Benjamin. I am a physician by training, an internist, and the chief medical officer at Ariadne Labs. I work as a public health researcher. My background is in health systems and implementation science and quality improvement. I'm associate professor at Harvard Medical School, where I teach quality improvement and implementation and reliability. I've been very involved and very interested in communication and resolution programs for a long time. I had been the chief quality officer for a large health system in Massachusetts, where I implemented one of the earlier CRP programs and was fortunate to be able to create an alliance in Massachusetts called MACP, which I co-chaired, where we initially brought together 6 hospitals to learn from one another and test the CRP model and study it for its outcomes on patient experience, provider experience, and on costs as well. And it's from that early experience when I came to be the chief medical officer at Ariadne Labs, I really wanted to bring this interest and this model and think about how can we help others implement at scale CRPs. Ariadne Labs is an innovation center at Harvard School of Public Health. It was founded by Dr. Atul Gawande to really design solutions to improve healthcare delivery. And this really falls well within that realm. So really pleased to be here. Great,
thank you, Evan. And Tom, would you like to introduce yourself?
Sure, Tom Gallagher. I'm an academic general internist. I'm professor and associate chair of the Department of Medicine for Quality and Safety at the University of Washington, where I'm also a professor of bioethics and humanities. And those 2 appointments really symbolize what the focus of my career has been. How do we work together when something has gone wrong in a way that promotes accountability, communication, compassion, transparency, and learning? So I've spent most of the last 2 decades trying to figure out, both from a perspective of scholarship, but also implementation, how we can respond more effectively when something has not gone well in care. I became acutely interested in this actually as a medical student and as a resident when I had experiences with significant errors that harm patients. And in both of the cases that come right to mind, nobody was willing to talk with the patient and family. There wasn't any learning, there was no accountability, and the healthcare team really just put their heads down and moved on to the next patient. And I came to learn over time how responding to harm events in that way just really makes things so much worse for patients and families. It's like pouring salt in their wounds. It makes things worse for clinicians. There's no learning, there's no accountability. And I thought to myself, there's got to be a better way. And that work ultimately led to the development of what are known as communication and resolution programs. As we were working on lots of large grants in this area, we also realized that there were all sorts of institutions who were working on this topic and stakeholders who were acutely interested in advancing a principled response to harm, but everyone was working in isolation. So we founded the Collaborative for Accountability and Improvement about 6 years ago to serve as a not-for-profit hub for best practices in communication and resolution programs, with a mission of trying to advance highly reliable communication and resolution programs and as far and as wide as possible. We've got an outstanding board. We have a variety of committees working on things ranging from best practices to policy to research and innovation. We've got an outstanding patient and family advisory committee. So it's a community of folks who really are committed to how do we advance our mutual goals around making sure when something goes wrong, we respond in a way that supports patients and families, supports the clinicians, and drives learning and accountability.
Excellent. Thank you, Tom. And Allison, can I ask you to introduce yourself?
Yeah, thanks, Melissa. Hi, everyone. So nice to be here with you today. I'm Allison Perry. I'm a Senior Director of Faculty and Fellows at the Institute for Healthcare Improvement, or IHI. I've been in the field of patient safety and quality improvement for 16 years, and just looking at some of your names and faces, I've had the pleasure of working with several of you as well on this call, so nice to see you. I've spent many of those years focusing on patient and family engagement and communication, and IHI will be celebrating its 30th anniversary next week, actually, if you can believe that. For 30 years, IHI has been supporting organizations in implementing and spreading improvement methods and opportunities, and providing leadership and training around safety and quality to millions of people in health systems around the world.
Great, thank you. So now, Tom, I want to give you the challenge of telling us in 3 minutes what a communication and resolution program really entails.
As I mentioned, I think all of us who are clinicians or quality and safety or risk professionals know that everyone goes into healthcare to try to provide the best possible outcomes we can for our patients. But unfortunately, despite our best efforts, sometimes things go wrong in healthcare. Patients are harmed by the care that is intended to help them. Sometimes there are errors that cause those harms. And we just continue to see that, when harm events happen in healthcare, the natural reflexes and inclinations that all of us have, our desire to be open, our desire to support and comfort the patient, our desire to make things right and to learn, they oftentimes get overwhelmed by these competing reflexes that we have to want to keep things to ourselves. We're embarrassed as individuals and organizations. We don't know what to say or do. We just put our heads down and hope that everything will blow over. And that just makes the situation far worse. So communication and resolution programs are comprehensive, they're principled, they're systematic programs both to prevent and to respond to harm events. Each of those descriptors is really important. They're comprehensive. They have multiple elements that I'll describe in 1 minute, but starting from culture and early event reporting and going all the way through financial, non-financial resolution, patient and family engagement. They're principled. We use them every single time there's been a harm event. They're systematic. All of those different domains are hardwired to work together, which I think has proven to be one of the biggest challenges in the field, because many of the organizations who are doing work in this space have all of the different elements, but they're not hardwired to work together. That's what a communication and resolution program is. It involves those different pieces: a strong culture and climate of safety, effective event reporting, open, honest, ongoing conversations with patients and families about what happened, event analysis and quality improvement that focus on system breakdowns and solutions, financial and non-financial resolution, patient and family engagement, and clinician support. As I mentioned, when I've been involved in serious harm events, for the most part, we pretended like nothing happened. We put our heads down, we moved on to the next patient. You wouldn't want to be the next patient that we rounded on. wasn't particularly good for us as clinicians either. The major challenge, though, that we see in the field, and we're so excited that several hundred organizations are now in some way working to implement communication and resolution programs. The biggest challenge that we see is one of inconsistent implementation. Organizations using some parts of the CRP process, but not the whole model for a given event, or using it for some events, but not for others. And that's really what we created PACT to address. And it's great. I see folks from UW Medicine. I see Doug from MultiCare, to have organizations that are already committed to PACT present on the call, who can help chime in about why they think CRP is so important and why PACT is so important. But with that, let me pass things over to Evan, who can tell you a little bit more about how PACT was created to help organizations implement highly reliable CRPs. Evan?
Evan, you're muted.
It's only 18 months in the pandemic and I'm still unmuting. We're really proud that these three organizations came together really out of common interest to facilitate wide-scale implementation of CRP. We brought together Ariadne Labs, where I work. Ariadne really has fantastic skills in designing and scaling new solutions. We're primarily a design and test shop, if you will, where we design new approaches for improving healthcare delivery. At the University of Washington with Tom and his CAI organization, who've obviously been working for many years at understanding and trying to improve response of after harm events, and the Institute for Healthcare Improvement and their long experience in creating collaboratives and bringing organizations together to work in alliances to improve care. So PACT is an 18-month collaborative. It's based on the methodology of the IHI Breakthrough Series methods. And what we want to do is we're going to bring together a learning and action community to help create what we are calling highly reliable CRP programs. Through the methodology where we have learning sessions and action periods, there are really four major components that we will bring to our health systems engaged in the collaborative. The first are actual tools and solutions and guides, which we've designed to help implement CRP. We've reviewed the best practices and learned from others what are the processes and the steps that are necessary in an effective CRP program, and then ended up with a set of tools and solutions. We'll bring these tools and solutions together with best practices from others, how to manage a case, how to communicate with patients and families, and through case-based discussions where we all will teach and all learn. We'll have a series of best practices learning sessions for how to respond to patients, particularly after harm events. The third area is around measures. We have studied and created a set of measures to help evaluate how CRP is going, how it's working in your organization, and how you could use those measures to help benchmark your success, as well as see your progress. And the last area we'll bring together in this collaborative is really faculty coaching, really expert faculty who've been in the field working in CRP programs to coach both during the learning sessions and during the action periods, following along and working with you and your teams to really facilitate the successful implementation. So we are very excited by the concept of a PACT collaborative based on the IHI methodology, bringing together three highly skilled organizations. I think that's sort of this quick summary of what PACT is.
Yeah, great. Thank you. So now we'd really like just use the rest of our time a little informally. We can have some discussion. Please feel free to unmute and ask a question, or we can comment aloud, or drop something into the chat, and I'm happy to read that for you. And if anyone has anything they'd like to start with, please feel free. And if not, I can also move on and maybe keep the ball rolling while you think of a question you'd like to ask. All right. So Tom, I wonder if you could talk a little bit about why this is the right time for the PACT Collaborative.
Well, one of the reasons why progress in the field has been slow up to date is that there hadn't, up until the last couple of years, been really effective tools and resources to support CRP implementation. Lots of organizations were aspiring to implement a CRP, but were struggling with figuring out the how. And starting with the release of the Candor Toolkit, which we and others helped to build, the field, the availability of resources and tools to support CRP implementation has just grown and grown and grown. And one of the things that I'm so excited about with PACT are the new tools and resources that build on that framework and really bring best-in-class resources around things like patient and family engagement, supporting patients, supporting clinicians and the conversations with patients and families about harm, leadership engagement, all sorts of new tools and resources that will help organizations achieve high reliability in CRP implementation. It's also the right time because there are measures, as Evan said. I think the vast majority of organizations that we've worked with don't have really any way of knowing how well are their CRP processes currently functioning. Even basic things like how many events have you had in the last year that ought to have gone through a CRP? And of those, what proportion actually did? The PACT Collaborative, and Evan and I worked together with generous donations from 3 different patient and family advocates to build and pilot test a measure set for CRP that will allow organizations to answer that question. How well are we doing benchmarked against their peers? And then lastly, it's an important time for CRP. Not only are the right tools available, new measures are available, but the liability insurance climate just continues to get more and more challenging. And we had a piece in JAMA about a year ago talking about that and why CRPs are such an important response to these environmental challenges, because they really allow you to have a much more structured and effective process for responding to harm, to support patients and families, to drive quality and safety, but also to experience improvements in liability expenses.
Great. Thank you, Tom. I see we have a question about the process for application and what information is needed for the application. And so I can take that one. It's not actually a lot of information that we're asking for, but we do ask that you have a letter of support from an executive sponsor of your organization who's able to speak to your organization's commitment to CRP and tell us a little bit about what you're already doing related to CRP. We know that as Tom and Evan have talked about, there are a lot of organizations that are already doing this work. And our hope is to, for the most part, bring together organizations that have already started their CRP, that aren't coming to this collaborative to be convinced that this is the right thing to do, but have already decided this is the right thing to do. And they're looking for support to do it better, deeper, with greater reliability, right? So it's not an extensive application, but I think it's an important one. And it invites you to think a little bit about what you're already doing. And
Melissa,
Nicole, thank you for sharing that info.
I wonder if I might pester Doug for just 1 second. So Doug Jaquez is head of risk at MultiCare, one of our flagship participants. Doug has been working in this space for a long time, and it's great to see you on the phone. Doug, would you be willing just to say a word or two about why MultiCare was so interested in joining this initiative and what you're hoping to get out of this?
Yeah, definitely. I came to MultiCare a little over 2.5 years ago. Prior I was at Swedish in Seattle, and where we had a CRP program that was maturing. And this was part of working with Tom since I think 2010 through the collaborative. Our leadership are already bought in with CRP. We've had to deal with some restructuring so we can move forward. Primarily our insurance platform didn't allow for the CRP process. So we've made all those changes effective September 15th. And this PACT collaborative just happened to happen the exact same time I wanted to go start our journey. And so that's why we're so excited. And we feel that this is part of our HRO journey. We don't consider this a separate process. So again, we have a lot of buy-in for this.
Great.
It's really interesting to hear, Doug, about the HRO journey. We've had a few other systems who are joining the collaborative who have said the same thing, that they've been on an HRO journey and they felt that this fit in exactly with the work that they're doing there. So I think you'll be in good company, as I'm excited to hear you mentioning that.
Thanks.
And their MultiCare joins a group of either, I'm losing count a little bit, 15 or 16 other organizations who are committed, bringing over 30 facilities. We do have room for a few more, but all of the organizations that are committed already are those that are doing their CRP work and wanting to achieve a higher degree of reliability. And so one of the things that Allison might want to say a little bit more about is, this as a true learning collaborative and how the Breakthrough Series really, it's not only about the didactic teaching and the new tools and resources, it's the ability to learn from organizations like MultiCare and people like Doug who have been in the trenches for a long time, learn from one another. And it really shouldn't be seen as a new initiative. This should really be for organizations that are doing this work to some extent already and wanting to achieve a greater degree of reliability. But Allison, I would love to hear more from you about why the Breakthrough Series model is such a powerful way of driving improvement in ways that really stick.
Yeah, absolutely. So Tom, I think that's an important piece of information to share about this model. So a Breakthrough Series is not an innovation model. That's not this space. So as Tom was describing, we actually go into this with existing knowledge, best practices, and that's actually how we get the results that we intend to get in a relatively short period of time. Just a little bit of history. The Breakthrough Series model was designed in way back in 1994 when IHI's founders, Dr. Paul Batalden and Don Berwick, sketched out a model at a meeting as a napkin sketch. And it was designed because they were discussing how successful IHI had been in training thousands of people from hundreds of organizations on how we improve. So there was a lot of knowledge and a lot of will, but then the question was, how do we get people to get this done? How do we get them to do the work effectively, to really make system level changes that impact care? And so that's how the model was created, and that's how we're using the model, how we've incorporated that into this program. So we have expert faculty who have the knowledge and expertise around CRP best practices, and we have organizations from around the country participating and committing to accomplishing a common aim. And I think the other piece that I'll just add, this is IHI is very much all teach, all learn is a best practice that we often use, and that will very much be this collaborative. This structure will be a series of learning sessions coupled with then you go back and you'll do plan, do, study, act, PDSA cycles that and we'll have dynamic and interactive learning sessions. So I think Tom really is correct that it's the folks who are participating and already committed are key to the success of this program. And we're fortunate to have so many organizations already enthusiastic about this work.
Great. Thank you, Allison. I think we have time for maybe one more question or comment if someone has anything else they wanted to ask or share today.
I'll just comment. I'm not with the hospital. I'm CEO of a tech company that strangely, and maybe first time ever, was generated from CRP. There was a MPL carrier is one called Constellation, MMIC, UMIA. And they were sort of going whole hog in on CRP because their hospitals were asking for it. And they said, we think this is the future. But there's some really structurally difficult things for carriers to do in order to support CRP. They can't do things fast enough. A harm event happens, things like that. It was taking months to sort of get their arms around a case to be able to come back when they wanted to, respond quickly. And so they actually developed this concept that became its own company, which is the company I'm running called MedPlace. But, the idea was, how do you take a 3-month process at a carrier and bring it down to 9 days? And that ends up being a technology problem, interestingly. And I don't hear that enough in the space, and I don't really even understand fully where the problems are with CRP, where the friction points are to help sort of condense timeframes and bring things closer. But I find it really fascinating. And one of the things I'm listening for is where could technology come in and help facilitate things, like whether it's bringing experts in on demand who understand and can help with particular cases or programs, or whether it's facilitating the movement of records and information between a lot of disparate parties, which can get really convoluted and create a lot of finger pointing and things like that. So I'm really just here to kind of listen, but we're also supporting the PACT. And anyway, I'm here to sort of like try to look through the lens of technology and see where there's opportunities to sort of maybe address some systemic or structural friction points.
Right, and just word of wise, and here's a potential. When starting up CRPs, they start to come quick. So I compare this as a rookie in the NFL, that the game is so fast that it's easy to lose your place. So I encourage people that are going on is figure out your tracking methodology before we get started, so you know which cases are in the CRP pipeline and what node they are, because that's where you're going to fail, because you forget about a patient. It's just going to make the program non-functional.
And having folks like Jared a part of this is just so great, because as you can tell, he brings a completely fresh perspective and a new set of tools and resources to help solve some of these challenging problems. So it's just one example of the sort of the fresh approaches that people will be experiencing in PACT.
We're very appreciative of Constellation's support. Really allowed us to kick this off, and Jared, would be great to have you engaged.
Thanks for having us. Anywhere this conversation is happening is important. I've seen the impact on physicians that get these things resolved for themselves quicker. I've seen the impact on the patients. So I don't come from this industry, but I have had healthcare, and I do have family that's been on the receiving ends of these, and it's good to hear that this conversation is happening. So however we can support it, happy to.
Well, thank you all for joining us today for this conversation. Nicole, do you want to pop up that slide with our website? And just would invite you all to visit our website and learn more about PACT. And please feel free to reach out with any questions that may arise later. Thank you again.
Thank you all.
Bye-bye.
Thanks, everyone.
Thank you.